Good afternoon, everyone, and thank you for joining today's webinar. My name is Melanie McGacken, and I'm proud to be representing the Rutgers Community Living Education Project team, usually referred to as CLEP. The CLEP team provides education, training, and resources regarding the many possibilities of community living within the state of New Jersey. CLEP's support and services are made possible through funding from the New Jersey Division of Developmental Disabilities. The CLEP team contacts will be shared at the end of today's presentation, so feel free to give us a call if we can assist you in exploring community living opportunities. Before we get started, let's go over how you can best participate during today's virtual event. To ensure the best sound quality possible, all attendees will initially be muted during this presentation. This session is a wonderful opportunity to learn about a topic relevant to our community, so we encourage you to ask questions, share your thoughts, and engage during today's presentation. You can do so by using the Q&A section of your control panel or the chat feature if you want to chat with other attendees during today's webinar. At this time, I would like to introduce a fellow parent and today's presenter, Janet Shouse. Janet will be guiding us through the IDD Toolkit, Tools to Enhance Healthcare for Adults with Intellectual and/or Developmental Disabilities. The toolkit offers healthcare providers best practice tools regarding medical, mental, and behavioral health concerns. The IDD Toolkit also offers resources for patients and families because effective healthcare can be best achieved through a collaborative approach. Given Janet's experience and expertise in this field, she is a valuable resource to share actionable strategies on this topic. So please join me in giving a warm virtual welcome to Ms. Janet Shouse. Janet, thank you for being here today. I'll hand the screen over to you.
Well, thank you, Melanie. I appreciate this opportunity to talk to this group, and I am always happy to talk about this topic. It's personal for me, as well as professional. So I hope that I can provide some useful information to you all. Let's see if my slides are going to work now. You've already seen this, so we'll go right to who I am. I am not a healthcare provider. I spent almost 30 years as a newspaper copy editor and became active in the disability community shortly after my son Evan was diagnosed with autism at the age of 2 in 1998. So I'm old, and I've been at this a long time. I joined the Vanderbilt Kennedy Center in Nashville in 2010 as a parent mentor with what was called the Parent Stress Intervention Project. We were doing 2 different interventions with parents of kids with disabilities, and the principal investigator wanted parents of kids with disabilities to do those interventions. One was based on positive psychology, one was based on mindfulness. I did the positive psychology because I had absolutely no training in mindfulness. The day that project ended, I was hired to do what was called the IDD Toolkit project in 2013. And this was taking consensus guidelines and tools that were created in Canada, and we Americanized them and put them online. And I'll talk more about that very shortly. I also worked on a project called Tennessee Works, trying to improve the employment landscape for people with disabilities for a little over 8 years. And then I've also been involved in several ECHO projects, which is a way to train healthcare providers to better serve people in a particular area. One was about autism adult healthcare, and one was more broad about intellectual and developmental disabilities. A little bit about the Vanderbilt Kennedy Center. For those of you who don't know, we are the Vanderbilt Kennedy Center for Research on Human Development, not to be confused with the musical performance venue in Washington, D.C. We have what we call the 4 pillars of the Kennedy Center. We are an intellectual and developmental disabilities research center, which is more hard science or bench science into intellectual and developmental disabilities. So using mouse models and cell division and zebrafish and that sort of thing. I work for the University Center for Excellence in Developmental Disabilities, which is more about social and behavioral interventions or educational interventions. We work more with real people, and we also do technical assistance and disseminate the findings of the research. We also have what's called the Leadership Education and Neurodevelopmental Disabilities Program, which trains 13 disciplines, pre-professionals to become leaders in the field of neurodevelopmental disabilities. We train pediatricians, we train nurses, we train teachers, audiologists, occupational therapists to really, they get an additional 300 hours learning about neurodevelopmental disabilities. And then we have what's called the Treatment and Research Institute for Autism Spectrum Disorder, or TRIAD. And it has a large contract with our state Department of Education to train teachers and administrators and paraprofessionals on how to better serve students with autism or other behavioral disabilities. So why are there issues with caring for adults with intellectual and developmental disabilities? One study found there were multiple comorbidities in adults with IDD, and among the physical health conditions that are more prevalent are epilepsy, constipation, vision impairments, hearing loss, obesity, skin problems such as eczema, gastrointestinal issues, thyroid disorders, and Parkinson's disease. So those are just some of the things that are more likely to be seen in a patient with an intellectual or developmental disability. There are also multiple comorbidities in adults with IDD in terms of mental health conditions. And the communication issues involved sometimes with adults with IDD make it really difficult sometimes to diagnose these. But the conditions that are more prevalent include schizophrenia, bipolar disorder, anxiety, depression. And while dementia does occur, it's a small proportion of people with intellectual and developmental disabilities, but it occurs at a much earlier age. Many of you may know that individuals with Down syndrome often begin experiencing symptoms of dementia as early as 35 or 40. And then among youth and adults with autism who do not have an intellectual disability, suicide risk is much greater. It may be 2 to 7 times higher than for those who don't have autism. And you will hear me speak primarily of people with autism. I'm old. I grew up in the era of person first language. I do try to use autistic and neurodivergent, but those don't flow off my tongue in quite the same way as people with autism. So please do not let my language offend you. And if somebody wants to take me to task, please feel free to do so. There is increased mortality for adults with intellectual and developmental disabilities. I won't read through all of these, but the most stunning one for me was the fact that adults with cerebral palsy live 23 fewer years than the typical population, and that there are racial and ethnic inequities that are most pronounced among those adults with cerebral palsy. So it's an issue of length of life, often because our folks don't get appropriate care. The average age of death among people with IDD, this is from 2017. This was the most recent data I could find. And it shows that, there are areas where people die at a much earlier age who have an intellectual developmental disability. So what are some of the health challenges that people face? Well, many of our loved ones or the patients we're serving have complex and frequent co-occurring medical conditions, as we just saw. Many of them have difficulty communicating symptoms or their history and even where they hurt. And this can include people who are pretty communicative. They may have difficulty locating where the pain is. And then they may have difficulty understanding the treatment options. If the treatment options are not laid out in very plain language, and in some instances, they may have to have a conservator to make those treatment decisions. They may have an atypical presentation of health. They could be very, very sick and not running a fever. Or I've actually had families tell me that their child or adult son or daughter had a broken bone that wasn't recognized for weeks because of the way the person presented themselves. They did not seem to be favoring that foot or that arm or whatever. And for many of our folks, there are significant sensory issues that make healthcare appointments highly stressful. They have difficulty waiting, they have difficulty with fluorescent lights, they have difficulty with crowded waiting rooms. And so they may respond in negative ways in a healthcare setting. And many of our folks have experienced trauma, both throughout their lives and medically related trauma. You know, being restrained for a blood draw can be traumatic for an individual. And if that happens over and over again, it really does become a traumatic experience to even go to a clinic or a hospital. Some additional challenges that our folks face, they may have difficulty accessing healthcare, either because they can't get in the building, because it's not accessible, they can't be weighed because they're in a wheelchair and there are no scales for them, they can't get on an examination table, or financially. While some of our folks have insurance through Medicaid, a lot of healthcare providers don't take Medicaid. And if they're not able to work and get health insurance that way, it may be difficult for them to financially afford healthcare. Oftentimes there is inadequate or inappropriate healthcare. Sometimes a matter of pain is dealt with a psychotropic medication because it's seen as a behavior issue, not as a pain issue. There's often little or no preventive care. Unfortunately, sometimes it's just considered too much work to get someone in for a mammogram or a pap smear, because they may act out and respond negatively in the healthcare setting because of they don't understand why this is being done. There is research that shows there is clinician bias against people with disabilities broadly, and that can play a role. And we know that medical research often excludes adults with IDD. So some of the additional challenges, we may not know what works for people in this population because the research hasn't been done in this population. And then health promotion materials are often not written in a way that is understandable to people with intellectual and developmental disabilities, or provided in Braille or video or whatever, so that the person can understand what they're being asked to do to promote their health. Some concerns of practitioners, this comes from a study from 2014. Many healthcare providers have had little training or experience with folks with intellectual and developmental disabilities. I often find, I will say, that the people who are doing this work are people who either have a child with a disability, or a sibling, or an aunt, or somebody who lived across the street that they were good friends with that had a disability, and they had that personal experience. Many folks worry about the patient's lack of communication. Pediatricians are used to dealing with young patients who cannot communicate well, but there's generally a parent there who can tell the physician or the nurse practitioner what's going on. In many instances, when adults with intellectual and developmental disabilities go to a healthcare professional, they may be with someone, a direct support professional, who's been with them for 3 days, who has no real idea of what their history is or how they best communicate. As I mentioned, attitudes or discomfort about people with disabilities, the clinicians themselves acknowledged that they feel this discomfort. There's something called diagnostic overshadowing, in which the individual, whatever symptom they're displaying, is considered to be part of their disability and not a separate issue, such as they're banging their head because they're autistic, not they're banging their head because they have an ear infection or they have a tooth that needs to be pulled, or they're acting depressed. Well, it's because they have Down syndrome and they're feeling excluded. Well, no, maybe they actually do have depression and need treatment. There are concerns about issues of consent. Is this person capable of providing consent to the treatment that the healthcare professional is suggesting? And then feeling overwhelmed. There's a lot to do in taking care of adults with intellectual and developmental disabilities, and limited time. Many times our folks take more than the standard 10 to 15-minute appointment, and there just seems to be so much that needs to be done. And then there are reimbursement issues. If the standard appointment is 15 minutes and this person takes 30 or 40 minutes to really get to the issues and provide appropriate care, that healthcare professional has lost money while taking care of that individual. So that's why we have the IDD Toolkit. It was originally created as tools for the primary care of people with developmental disabilities and published in 2011 in Ontario, Canada, as the Canadians moved people out of developmental centers and into the community. They wanted their family physicians to have tools to really be able to serve this population. They were afraid that these individuals would be moving into the community and not have the kind of care that they'd had in those developmental centers. And there were consensus guidelines created, and then they found out that doctors don't always read consensus guidelines, so they created tools, which I learned early on is sort of like a Cliff Notes version of the consensus guidelines, and really helps walk the healthcare clinician through what needs to be done. The creation of the original toolkit was a partnership between the Vanderbilt Kennedy Center, USAID, and our LIND, and our Department of what was then called Intellectual and Developmental Disabilities in 2013. And Dr. Tom Cheatham, who was the Deputy Commissioner for Health Services at DIDD at that point, was one of the creators of those consensus guidelines that I mentioned that came out of Canada, and he helped create the tools. And he helped us here at the Kennedy Center get a grant from the WITH Foundation. And the WITH Foundation stands for Working for Inclusive and Transformative Healthcare. And it is a group out of California whose sole mission is to improve healthcare for adults with intellectual and developmental disabilities. And so what we did was we took that book and we put it online, because in those days, they didn't have an online presence really. So we took those tools, we adapted them to our American healthcare system, some language differences and stuff. And our toolkit has been accessed from people in 193 countries over the course of the last 10 years. And then we revised the toolkit in partnership with the folks in Ontario, Canada, a group at Surrey Place in Toronto. And we had an advisory committee made up of healthcare providers, families, members, and individuals with lived experience. And we launched our new site in April of 24. So there have been some revisions in the toolkit since it first launched. This is actually the home page of Surrey Place, which was the organization that really led the primary care guidelines and the creation of the tools. And if you want to explore the Surrey Place guidelines, you can do so here. Some of the adaptations we made to our US healthcare system, we changed some language. They used a phrase called behaviors that challenge, which if you use the entire phrase, it is behaviors that challenge supports. So if people were having behaviors that might risk them losing their place in the school or in a supported living situation, that was the behaviors that challenge. They felt like it was a better term than challenging behavior, but our advisory board felt like distressing behavior or distressing behaviors was more appropriate. In part because many folks in the US don't have a lot of supports and services. And we chose to use family and support person rather than caregiver, in part because we know direct support professionals are really pushing to be seen as more than caregivers. They really are wanting to be seen as support people. And because a lot of our advisory board was not familiar with the idea of co-regulation, which is coming out of the whole notion of trauma-informed care, we use the phrase staying calm in a distressing situation rather than co-regulating with the individual. We also changed some process ideas because the processes in Canada are different than they are in the US. Canada has supports and services that just aren't always available in the United States, and our private insurance system varies dramatically from the Canadian healthcare system, where everybody is assigned a family physician and you go through the family physician to get whatever care you need, and they coordinate the care. So who can use the IDD Toolkit? Well, it's primarily aimed at healthcare clinicians. We also have sections for mental health providers. We hope that people with disabilities will use it, and family members and support persons. So this is the home page. It's not a very attractive home page, but we set it up based on what our advisory committee said they wanted. And so here's the way to get to the home page. And I'm going to kind of walk you through what you can find here. And I hope you will explore it on your own later. In the primary care appointment, you'll find what we call approaches to care. And the first thing we talk about is communicate care. And I'm going to run through these pretty quickly. I'll show you the tools themselves very shortly. But the things here are really targeted toward the healthcare clinicians that are in blue. And we'll go through. So the communicate care talks about how to interact with someone with an intellectual or developmental disability if you don't have personal experience. And the care stands for communicate clearly, attentively listen and observe, responsively address those concerns during the healthcare visit, and then engaging the patient and others. One of the things that's really kind of aggravating to me as a parent is when the clinician only talks to me. I mean, my son does not have the ability to communicate his pain, his symptoms, his history. But I really want the provider to engage with my son because I can hear his questions to Evan and I can respond. But interacting with Evan is important for me as a parent, and it's important to the people themselves. We've heard that from our advisory board. So this just kind of gives you an idea of how to best interact with a person with an intellectual or developmental disability. Here's a tool about decision-making, and it actually walks you through, can the person make their own decisions? Do they need support in making their decision? Or do they have a substitute decision maker, a conservator or a guardian? There's a section about frequently asked questions about when to get a genetic assessment for an adult with an intellectual or developmental disability. They may come to you and have a diagnosis of simply intellectual disability, but you don't know if there's any specific etiology of that intellectual disability. And then there's a section about adaptive functioning and communication of adults with intellectual and developmental disabilities. Again, this is for people who don't really have experience working with folks with IDD. And I will tell you, the use of age and grade equivalents in this tool, family members and self-advocates were not real keen on that, but we felt like for people who aren't accustomed to dealing with someone with an intellectual disability in particular, knowing that they operate at a 6th grade level or something like that can be helpful in just trying to kind of get a grasp of where the person can communicate and how they can adapt and respond to treatment. In this same section, there are some tools for individuals with disabilities and their families. And these are my healthcare visit, my hospital form, and about my health. So my healthcare visit is for a particular visit on a particular day. So the person, if they want to, can fill this out. You print out this form and it explains to yourself and to the healthcare provider why you're coming to see the doctor. Is it a routine visit? Do you have a problem that you want to be seen about today? It includes your medications. It also has a section for the doctor to say, you know, this is what we want you to do. You need to take this pill at a certain time, or you need to go to this therapy at a certain day. And it just helps the person remember what they're doing and why they're there and what they need to do when they get home. It can also be useful for the family or the direct support professional. There is the hospital form, which really came out of COVID, when there was a time when we were not going to be permitted to go into the hospital with our son. I mean, I didn't personally create this form, but this was where it came out of. And it does give important information about how the person communicates, what they need in terms of supports to do well in a hospital setting. And it really does walk families and individuals through thinking about what are the important things if I'm in a hospital setting that I need to function well and to get well. You'll see this form looks a little different. This is actually from the Surrey Place site. We did not go in and change this. And so there are some Canadian mentions, like it down here, it says my drugs are paid for by the Ontario Disability Support Program. But we felt like there were other kind of health passport things available that we did not, because we had limited time and funding, we did not go in and change this form. But if you want to, this is a great form to kind of give an overall health picture for someone. If you're, say, moving to a new provider, healthcare provider, you can fill this out and it really does take you through sort of an overall health view. Under physical health, we have what's called the health check, which is sort of a well check for adults with intellectual and developmental disabilities that specifies certain things you're not going to ask of a typical patient, such as communication, daily living. Do they have a cause associated with their IDD or DD? Who to contact about appointments? What accommodations are needed? And then it walks you through a whole series, and you'll see that on the next slide. Dr. Cheatham had a little checklist from 30 years of providing care to adults with intellectual and developmental disabilities that he used if someone was displaying new or concerning behavior issues. And this is just kind of a little cheat sheet that he had. And as an homage to him, he passed away in 2018. We have included his little checklist. And so here's the health check. And it walks you through, as I said, sort of a well visit. And it gives you some ideas of some differences you may want to think about as you're speaking with this patient as opposed to a typical patient. And then we have another section that's we've termed expanded explanations. And this document is connected with the health tool to outline some of those key differences. And the one about sexual health really stood out to me because, you know, when you talk to a typical patient, if you say, you know, are you having sex with someone? The person very likely knows what you're talking about. But for a person with IDD, what does having sex mean to you? Does that mean kissing someone? Does that mean holding their hand? Does that mean cuddling? Or does that mean actually having sexual intercourse? And it does walk you through some additional concerns that you might want to think about with that patient. There in the new revised toolkit, we now have multiple tools for epilepsy. There's general information for people who don't know anything about seizures. There are tips for families and support persons who are working with someone who has seizures. There's an action plan and a baseline record and then a first aid form. So, and then we have a whole series of monitoring charts. I included the bowel movement chart because this was very exciting to a couple of our clinicians. They really liked the idea of being able to monitor the bowel movements, but we also have for women's periods, for blood sugar, for food intake, for weight, that you can print out and send home with families, or that families can use, or support persons. We also have health watch tables for particular syndromes. So there's an autism health watch table, Down syndrome, fetal alcohol spectrum disorder, Fragile X, Prader-Willi, Williams syndrome, and something called 22q11.2 dilution syndrome. And it is a review of body systems. It tells you what things are more likely to be prevalent in this particular syndrome, and then it gives you recommendations as a clinician. And while this is targeted to healthcare professionals, families can use this as well, although the language is strictly for healthcare clinicians, because it talks about strabismus and refractive errors and, you know, high arched palates and dental malocclusions. But if you as a family member or a support person, you may want to print this out and take this with you to your healthcare provider. Under mental and behavioral health issues, there are a whole series of things, and I'm going to highlight a few of them. One is called the initial management of behavioral crises, and this is in a primary care setting if a person shows up and they're having a behavioral crisis, and it kind of walks you through what to think about. There's identifying symptoms and signs of mental distress in a person with an intellectual disability, and we'll see that tool in a moment. And the purple is really a tool that can be used both by the primary care provider and the family or support person. And we'll look at that in a moment. There's a risk assessment tool, which we'll look at in a moment, to see if the person's behavior is a threat to themselves or others. There's an emergency room stabilization protocol, which really can help emergency room personnel interact better with adults with intellectual and developmental disabilities. There's a crisis prevention and management plan that can be filled out if the person doesn't have such a thing. There's something called My Coping Tool, which is really aimed at the person with the intellectual and developmental disability, figuring out how they best cope with stress and distressing events. There's an antecedent behavior consequence chart, because although that's something that applied behavior analysis uses a lot, we found that that's been a very popular tool over the course of the years for people to print out and use. And then there's a psychotropic medication review. There are a list of mental health interventions that you can consider as a clinician. And so here's kind of helping you identify the signs and symptoms of mental distress. And it talks about, you know, onset considerations, diagnostic considerations, intervention trials, and just working together to try to find out, is this something related to life events? Is this related to abuse? Is it a psychiatric disorder? This I really like. This is the health with emotional and behavioral concerns, because this HELP stands for health, which does the person have an infection? Do they have pain? Do they have a broken bone? And then if they don't have any kind of health issues going on and they're displaying really distressing behavior, look at their environment and supports. Are they in a place where they feel safe? Are their needs being met? Do they have enough support to do the kinds of things they want to do? Or are they over supported? You know, we have people who have 2 direct support professionals watching them 24 hours a day, 7 days a week. And sometimes people act out because they want to be left alone for a while. And then there are things about lived experience. We talked about trauma and adversity, and there are lots of times that people with IDD experience adversity in their lives, whether it's everyday stressors and triggers, or is it past trauma? And then finally, if all those things check out and seem to be okay, then think about whether the person actually has a mental health disorder or psychiatric disorder. Here's an example of a completed crisis management plan. And then there is a blank form for individuals and family members to fill out that talks about, normal calm behavior, what it looks like when the person begins to escalate, what looks like a crisis, and then how do you calm the person down. Here's the risk assessment. It does talk about suicide. It talks about self-harm or self-injurious behavior, self-care and neglect. There's also a page about aggression and threats to the people around the individual. Here's the mental health intervention tool. I didn't include the whole tool, but it talks about trauma-informed care, psychological therapies. It also talks about things like art therapy or physical exercise or things that the person could be doing to help keep them in a better mental health frame of mind. And then my coping tool is that, as I said, for the individual themselves, and they can draw pictures, they can write, but it's, when I'm feeling good and I'm my usual self, what are the things I like to do? What are the people I like to see? Where do I like to go? And then as I begin to feel more stress, how do I look? How do I feel? What can people say to me to help? And then what happens when I start to feel in crisis? And then how can I begin to feel back control of myself? And then the emergency room stabilization protocol, this actually came out of a family's interaction in one of our emergency rooms. And this was developed here locally. I don't know if you all are familiar with the National Center for Start Services, but it utilized, they have a prescriber's guidelines, I should say. And this was created with the help of those folks. And it really just walks you through, it's sort of a condensed version of that communicate care. And then we actually decided to create a separate section just for patient tools. So these are the things that are aimed at individuals with disabilities and their family or support persons. And it's the About My Health, so the overall kind of health passport view, the My Healthcare visit for a particular visit with a clinician, My Hospital form, and My coping tool. And then, as we said, the emergency room stabilization protocol may be useful to take to an ER visit. So some helpful resources for providers and families. I don't know if you all are familiar with the American Academy of Developmental Medicine and Dentistry, but this is a group that I'm a part of. You do not have to be a healthcare professional, and self-advocates and family members can be involved. And they really are aimed at improving healthcare for adults with intellectual and developmental disabilities. It is a great group. It is my favorite conference to go to. They offer a webinar series on neurology and IDD. They offer monthly grand rounds about all kinds of topics related to people with intellectual and developmental disabilities, including dentistry. And their conference is in June this year in Scottsdale, Arizona. If anybody wants to come, you can come and say hi. I'm planning on being there. For those who have mental health needs, there's the NAD. It used to be called the National Association for the Dually Diagnosed. They have gone away from the actual language there, and they just refer to themselves as the NAD, but they have resources and information really aimed at individuals with intellectual and developmental disabilities and healthcare providers who want to serve those mental health needs. This young man is the reason I do my work. This is Evan sitting on his giant beanbag in his apartment in supported living with his dad on the giant beanbag. And if you have questions, you are welcome to contact me. I actually prefer email to phone calls because it's easier for me to keep track of who I've talked to and whether I've talked to you or not. but it's janet.shouse@vumc.org. And just very briefly, we have a new project that is coming up that we're going to be looking for feedback on the IDD Toolkit, and we will be recruiting clinicians, people with lived experience, family members, and support. If you're interested, you can email the IDD Toolkit@vumc.org. And Melanie has asked me to share this slide. Yeah.
I'm with you. I'm back again, Janet.
Okay.
Thank you again for including our slides into your presentation. This
Sure.
is how you can best reach the community living education project. Again, we are through Rutgers University and funded through the New Jersey Division of Developmental Disabilities. Feel free to take a quick snapshot of that QR code on your screen. By doing so, you will receive our upcoming newsletter, any special announcements, information sessions, such as this fabulous one that we are hosting today. You will also see our contact information of the CLEP team members on your screen. Again, feel free to take a quick snapshot of that information. Also know that this presentation is being recorded, and we will send a follow-up email probably in the next 24 to 48 hours with a copy of this recording, and this information will also be in that. That email will make sure to get a copy of the presentation to you. And then Janet, key forward one more time. This is a QR code for CLEP's evaluation. Takes about 30 seconds. If you would be so kind to do that following today's presentation. Again, no pressure to do that right now. It may actually just pop up on your screen as we are saying our goodbyes after we get to our Q&A session. It's information that you provide us that better allows us to support our community moving forward. And then Janet, I know you had a closing screen before our Q&A.
Yeah, my funders and I would appreciate your feedback. I think there are 3 questions. You can take a snapshot of the QR code, or you can do the link, and it probably won't take you more than 90 seconds to complete that. So this just tells the folks who are funding me that either I've done a good job or I haven't.
You've done a fabulous job. I can assure you of that. So Janet, are you comfortable if we get to some question and answers at this time?
Sure. I couldn't see the chat, so I couldn't see if there were people clamoring questions.
So there are definitely some questions coming through the chat. We do have some in the Q&A section also. We do have a family who sounds like they are having some challenges. She's sharing that there's a big deficit in trauma-informed care that has really affected her family. Do you have any resources for families to share with their physicians so that they can better understand the importance of trauma-informed care?
Well, the mental health tools that we have on the IDD Toolkit do take a trauma-informed approach. So I would encourage them to look through some of those tools, like the mental health interventions and the initial management of a behavioral crisis and the risk assessment. Those are all things that really do take a trauma-informed approach. There are things out at the NAD website. There is a book by a woman named Karen Harvey about trauma in intellectual and developmental disabilities and healing from it. I can't remember the exact title. But if the family wants to reach out to me, I'm happy to provide more direct resources. Again, it's janet.shouse@vumc.org.
Fabulous. And I know that we have some fabulous professionals and family members on the call with us today. We actually have one of our past presenters that I'm sure, actually Melissa shared that she has shared your resources in the past at some of her presentations.
Cool.
So Can you quickly, if you're comfortable, go back to the slide, did it, where you were looking for some input from family and professionals? Is there a way to contact? Should they just email the IDD Toolkit at
Uh-huh.
umc.org if interested in participating?
Yeah,
Fabulous. So if you're comfortable leaving that up for a minute, Janet, and
sure.
we will give people the opportunity to jot that down also. And let's see, I know the one family that asked a question about trauma-informed care, the family has some very specific questions. I believe that mom will be reaching out
Okay.
to you directly. I do see that in the Q&A section. I think that's probably best, so she can get some really individualized responses if you're comfortable with that.
I'm always happy to talk to families or healthcare providers or people with disabilities.
Yeah.
Anybody who wants information about this stuff, I'm happy to talk.
Great. So we have a parent who has a young adult who is on the spectrum. Is it appropriate to give the toolkit to her son's primary care physician?
I would say yes. If there are particular tools that she thinks would be most helpful, might start with that. I'll be honest, sometimes the whole toolkit can be a little overwhelming. Uh, so you may want to start with, maybe the health watch table or some particular item that she's seen could benefit in that particular instance, and then maybe raise the whole toolkit. Because you do want to be sensitive. We're often asking healthcare providers to do something they haven't been trained to do. And I liken it sometimes to general education teachers who've had no training in special education being told they're going to have kids included in their classroom, and they feel ill-equipped. And you want to be sensitive to the fact that they have not been trained. And most of us, I think, I won't say most of it, many of us don't like to be given tasks that we don't feel equipped, that we know what we're doing. We like to do things that we feel we're good at. And sometimes because of the lack of training and the lack of experience with people with disabilities, it can be daunting. I'll share a brief story. I had lots of experience with people with autism and many kinds of developmental disabilities. But I had a colleague when I was working for Tennessee Works who had severe cerebral palsy, was in a power wheelchair, could not communicate verbally, used a iPad. She could move one hand slightly and she typed with a knuckle. And she couldn't feed herself or get herself a drink of water. And she was basically, one of my colleagues, and I was told, you need to give Lori a drink. And I was scared to death I was going to drown her. I'd never had to deal with something like that. And there were times when she sputtered and choked, and I thought, oh my gosh, I'm going to kill her. But it worked out. I didn't kill her. She's still around. But it was very scary for me. So we need to be sensitive and share the information judiciously, I guess I would say.
Absolutely. I think, as a family member whose adult son receives supports and services through a provider managed setting, we are extremely active in his life. And I think that what I saw in the value specifically in some of the tools is how it would really seems to build a collaborative approach to care, and might be a great resource for families to have to introduce, especially if they have other individuals who provide care for their loved ones or for themselves, so that information is being shared widely as long as the patient is comfortable with that, number one. And then in addition to that, I think some of the resources for the physicians who maybe don't have as much experience working with the population, that this might be, right, it's a beautiful introduction. Specifically, one of the tools was talking about how, I believe it was like how someone needed a break at times. It was a great conversation starter, right? To have with the person who is possibly receiving these supports, to say, this is how I want someone to support me during my appointment, prior, after, and during. I think we have to be more comfortable having these conversations, so that we can better understand from that person's perspective of what is and isn't going to work for them. So, perfect. We also have a family member asking, can a toolkit be used by the residents to come up with a crisis plan? So I'm assuming they're referencing a residential provider who supports their loved one.
Yeah, as I said, there is a blank form for crisis prevention and management that can be used to figure out, what is this person's triggers? What are we doing possibly that reinforces the distressing behavior? Are there ways we can think of to not reinforce that behavior, but reinforce behavior we want, the stuff that's going to make all of us happier? I mean, one of the things we know with my son is if he goes swimming on a routine basis, he is happier. And one of the things that's hard is if he's had a distressing event, then the support persons are often more reluctant to take him out. Well, the more he stays in, the more likely he is to have more distressing behavior. So you've got to overcome that fear that he might have. And believe me, one of my pet peeves is when somebody says, oh, Evan's having a behavior. And it's like, well, he's alive. So of course he's having a behavior. If he's having no behaviors, he would be dead. But that's just a pet peeve of mine. You can have maladaptive behavior, you can have challenging behavior, you can have distressing behavior, or you can have wonderful behavior. You can have good behavior. You can have, but if you're alive, you're not asleep, you're behaving. But that's just a pet peeve.
Absolutely. And it was the My Coping tool, How I Deal with Stress tool that I was referencing before. Again, I see such value in that as caregivers, professionals, family members, or for someone to identify for themselves, right? A beautiful conversation starter. I think that's I see that as a great starting point personally. I know I did put in the chat a link to your website. I see someone else is putting in a link also. So please feel free to explore the website further, delve in deeper. There is a lot to explore in the IDD Toolkit. See what's going to be the right documents for yourself or for you to introduce to either your or your loved one's physician, or for you to use as a family member with your loved one. Again, I think that these are all wonderful tools to really form a better collaboration for care and patient-centered care, just as importantly.
Can I get the chat? Because it looks like there's some really nice things being said.
Absolutely. So we will.
I couldn't see it before.
We will make sure, we're going to make sure that we get that for you. And I know we have about another minute or two, so if someone has a question that they want to get in before we say our goodbyes, please feel free to do so. I'll give you a second just to do that. I do see we have some wonderful physicians on a call with us today who really specialize in this field, and we are grateful that they are joining us. We do have a couple of upcoming webinars with the Rowan Risen Center. If you are joining us today, I will absolutely make sure that we get you those links via email. So if you're interested in those topics, we will make sure that you have the opportunity to register for those. I believe we have an April and a May session coming up with the professionals from Rowan Risen. So, okay. And this is, oh, perfect. You got such compliments coming in, Janet. Well deserved. I will say that for sure. So Janet, any closing remarks as we're preparing to sign off?
I saw someone asked about the conference in Scottsdale, aadmd.org. We'll have information about the conference. If you go, please holler at me. I'd love to connect. I really value my ability to connect and network with folks, because so often I meet someone over here doing this work and I meet someone over here doing similar work, and I get to bring them together, and that brings me great joy. So yeah, delighted to have this opportunity. So cool that you've got so many people interested in this topic. Yay! So I appreciate you reaching out, Melanie. And like I said, please, if somebody's got questions or concerns, or if you know of a clinic or a practice that wants me to do my song and dance for them, I'm always happy to do this. So thank you very much.
Fabulous. I see Dr. Iannazelli has shared that the Risen Center, who will be doing our next two presentations that will complement this session nicely. She shared that the Rowan Risen Center will be at the conference as well. So I'm sure that they're going to be one of the ones giving you a big wave and introducing themselves to you. So fabulous. Again, Janet, I cannot thank you enough. You know, I think sharing your expertise in such a family-friendly way, it's always welcomed. And we are absolutely grateful from the Community Living Education Project team to you for giving your time and dedicating your efforts to making sure that this information was shared. So thank you so much.
Well, thank you for the work that you do.
Thank you. Thank you. Greatly appreciated. And to everyone who joined us today, thank you so much again. As we're preparing to say goodbye, you're going to see a brief survey that's going to pop up on your screen. Again, please take it. Look for over the next 48 hours or so. I'll do my best to get that out for a copy of this recording, along with a copy of today's presentation via PowerPoint. Janet, thank you.
Thank you.
Bye, everyone. Be well.